Hello students, let us discuss one more module in image-based question in general surgery, that is module number 5, Hepato-Biliary and Pancreatic Pathologies. We are going to discuss the various case scenarios. Case number 1, a 40-year-old obese multiparous woman presents with acute right upper quadrant pain of 3 hours duration with history of fatty food aggravates pain. No history of fever or jaundice. On examination, Murphy sign is negative, but only tenderness was present. Total WBC count, there is no leukocytosis. Ultrasound of the right upper quadrant is shown here. So these are the three pictures and these are the 5 questions. So what is your most probable diagnosis? With this clinical feature, see, patient is having right upper quadrant pain only of 3 hours duration. History of fatty food aggravating pain. There is no history of fever. Murphy sign is negative. Total WBC count, there is no leukocytosis. With this ultrasound finding, the most probable diagnosis is biliary colic. So explain the findings in figure 1 and figure 2. So in figure 1 and figure 2, both are ultrasound of the right upper quadrant, where you are seeing clearly the gallbladder, here also the gallbladder, and inside also you are seeing the gallstone, here gallstone, and the posterior acoustic shadow also you are seeing, but you are not seeing the thickness of the gallbladder wall. In acute cholecystitis, usually the thickness should be more than 4 millimeters, and you are also not seeing any pericholecystic fluid collection. Okay, both are not there. And another thing is there is no sonographic tenderness with the ultrasound transducer. If you press that area, there won't be any tenderness. So these are the findings you will get in these two things. Explain the different types and its pathology of gallstones in figure 3. So here you are seeing the block stone. This is the cholesterol stone. These are mixed stones. So what are the three types of stones? Block stones are due to hemolytic anemias, which produce increased amount of unconjugated bilirubin. That is the cause for the block coloration. And in cholesterol stone, usually cholesterol and lecithin is to phospholipids. Ratio will be 1:30. If this ratio is altered, cholesterol gets precipitated and crystals form. Eventually, all these crystals will adhere together and stone formation will result. In case of mixed stones, it is always associated with infection. Okay, and there is an aphorism: gallstone is the tombstone erected in the memory of dead bacteria inside. So without infection, there is no mixed stone. This contains both the pigment and the cholesterol. Gallstone, what are the various modes of presentation of gallstone? Gallstone could be asymptomatic without any problem, or it could be a case of biliary colic, or it could be acute cholecystitis, or it can go for empyema of the gallbladder, eventually perforation producing biliary peritonitis, or one of the gallstones may go into the CBD through cystic duct and that will block the CBD, and this is called choledocholithiasis, and choledocholithiasis can produce ascending cholangitis or suppurative cholangitis. These are the complications of choledocholithiasis. Or the gallstone can also produce gallstone pancreatitis if it is going and obstructing the terminal part of the common bile duct. Gallstone can also produce gallstone ileus and Meniere's syndrome, which we are going to discuss in one of these case scenarios. I will discuss it in detail regarding gallstone ileus and Meniere's syndrome. So how will you treat this patient? It is not an emergency biliary colic. So you have to do you have to do a elective open or lap cholecystectomy. So immediately you can do conservative treatment. Symptomatically, you give some antibiotic, anti-inflammatory. You can even discharge the patient, and electively you can select a day and then you can do either a open or lap cholecystectomy. That is the management for biliary colic. Case number 2, the 50 years old lady complains of unrelenting acute right upper quadrant pain with fever. Unrelenting means it is continuous fever, not relieved by anything. Murphy's sign here it is positive. Leukocytosis is also positive. Ultrasound of the right upper quadrant is shown here. These are the 3 pictures and these are the 6 questions. What is your most probable diagnosis here? Patient is having the same right upper quadrant pain, but unlike the previous case, here the pain is unrelenting. Not just for 3 hours, it is continuous pain. Here Murphy's sign is positive and leukocytosis is also there, the inflammatory marker. Fever also will be there. Patient is also having fever. So with this clinical finding and with this, ultrasound finding, it is a case of acute cholecystitis. What you are seeing in figure 1 and figure 2. Figure 1 and figure 2, you are seeing distended gallbladder here in figure 1. But this gallbladder is smooth surface. It is just distended. Whereas in the second picture, not only the gallbladder is distended, you can see some gangrenous patches here and there in the gallbladder wall. So this is already a case of empyema of the gallbladder going for emphysematous cholecystitis. Okay, this is an acute emergency. You have to do surgery immediately. But maybe majority of these patients may be critically ill, so you can do only what is called cholecystostomy. You have to transcutaneous cholecystostomy. Put a drain into the gallbladder and drain all the infected pus. That's all you can. What you are seeing in figure 3. So this is an ultrasound of the right upper quadrant where you are seeing multiple stones. You can see not just one stone, you are seeing so many stones. And all these stones are having posterior acoustic shadow. Not one shadow, you can see many shadows for each one of these stones. Apart from that, there is gallbladder wall thickness of more than 4 millimeter, and you are also seeing pericholecystic fluid collection. See, that block thing around the gallbladder wall is pericholecystic fluid collection. If the patient is having number 1, gallstone with posterior acoustic shadow, gallbladder wall more than 3 millimeters, and pericholecystic fluid collection, and patient is also having sonographic Murphy's sign positive, it is a case of acute cholecystitis. How will you differentiate this from biliary colic? So this is what I want to show you. How will you differentiate? Acute cholecystitis is a somatic pain, whereas biliary colic is a visceral pain. Location of pain is usually right hypochondrium in acute cholecystitis, but if it is a biliary colic, pain will be in the epigastric region. The pain is usually more than 3 hours continuous, whereas in biliary colic, pain is usually less than 3 hours. Murphy's sign is positive in acute cholecystitis. Murphy's sign is negative in biliary colic. Fever is present in acute cholecystitis. Fever is absent in biliary colic. Leukocytosis is present in acute cholecystitis, whereas leukocytosis is absent in case of biliary colic. So if patient is going to, how will you manage this patient? Okay. If patient is going to come to you within 48 to 72 hours of onset of the symptom, you have to do emergency cholecystectomy, either open or laparoscopy. If patient is going to come to you after 72 hours of onset of the symptoms, treat the patient with antibiotics and anti-inflammatory drugs to cool down the patient and do elective cholecystectomy after 6 weeks, either open or laparoscopic. What are the complications of this cholecystectomy? Hemorrhage due to cystic artery injury, which we can manage it. Bile leak could be due to cystic duct leak or CBD injury. If it is cystic duct leak, you have to do a ERCP and put a stent inside. If it is CBD injury, that is dangerous complication, you have to do major surgeries like choledochojejunostomy or hepaticojejunostomy. That is the procedure you must do. Patient also may go for post-cholecystectomy syndrome, producing persistent pain due to retained stone or chronic diarrhea due to bile acid excess. These are the complications after surgery. Coming to case number 3, 45 years old female patient present with right upper quadrant pain and intermittent episodic jaundice for 7 days duration. There is no history of fever. History of clay color stool or pale color stool and high color urine, both were positive. These are the 5 images and these are the 6 questions. So question number 1, what investigation was performed as shown in figure 1 and what are the findings? So this is figure 1. This is what investigation it is ERCP. So in ERCP, you are seeing 2 filling defects. You are also seeing dilatation of both extrahepatic and intrahepatic biliary radicals. Both you are seeing. So this filling defect, most probably with this clinical scenario, looks like choledocholithiasis. Okay. And what is this picture? So this is a picture of this investigation is ERCP. Sorry, this is ERCP, this is MRCP because here, unlike the first picture, we are not seeing any endoscope here. So this is MRCP. So here also you are seeing the filling defect. 3 stones here. Okay, the same. Otherwise it is same. But MRCP is only diagnostic. ERCP is not only diagnostic, it is therapeutic also. You can do some therapeutic maneuvers using this ERCP. What are the 2 types of this pathology, choledocholithiasis? There are 2 types. One is primary stone. Stone in the CBD is developing primarily in the common bile duct itself or extrahepatic biliary radicals. That is what is called primary CBD stone, or this comprises only 10%. The other 90% of this choledocholithiasis, the stone develops in the gallbladder and through the cystic duct, it will come and lie in the common bile duct. This is what is called secondary type or secondary choledocholithiasis. This is 90%. Okay, what you are seeing in figure 3 and figure 4. Figure 3, this is an endoscopic picture you are seeing, and most probably an ERCP. Through the ERCP scopy, okay, they have introduced an instrument. It's an instrument called sphincterotome, this bow-like instrument. Okay, you are seeing a string. Through that, we had to pass a current and you had to cut the sphincter. This is sphincter of OD. So you have to cut the sphincter at 12 o'clock position because this is the avascular plane where even if you are going to cut it, there won't be any, bleeding. Why should you cut it first of all? Because you have to introduce this basket. This is called Damia basket inside. But if the sphincter is consistently, if it is in a sustained contracted condition, you cannot introduce this basket, Damia basket inside. For that purpose only, you have to cut this sphincter, and this is called sphincterotomy. And after cutting the sphincter, you can introduce this Damia basket inside, and one by one you can remove all these stones. Okay, this is what you have to do. This is called CBD stone extraction. Either you can use this Damia basket. If you don't have the Damia basket, you can use this balloon. This is called balloon swipe. Through this is the ERCP scope. So through this ERCP scope, so this is a side viewing scope. You can see it here. So through that you have to introduce this, this balloon inside. Then after introducing it into the sphincter of OD, into the CBD, you have to inflate it and then you have to pull it down. So while you are pulling it down, okay, all the stones inside Will also already you are seeing one stone is already it has been extracted and it is lying in the duodenum. So this also will come out of the sphincter of Oddi. It will lie in the duodenum and eventually it will come in the fecal stream. Yeah, you need not remove it actually. It will come in the fecal stream. Okay. What other follow-up treatment should be done in this patient? In this patient, apart from doing CBD stone extraction, either by Damia basket or by balloon swipe, you should also do cholecystectomy, either open or laparoscopic. This you can do either in the same admission or you can discharge the patient and you have to do it within couple of months. But you should do cholecystectomy because the origin of all these stones, 90% of these stones are secondary stones. The origin is only from the gallbladder. If you are not going to remove that fellow, that gallbladder, that will keep on, producing gallstone within no time, maybe in 3 to 6 months. Again, the stone will come and, lie in the CBD, that is recurrence of cholecystectomy. For that reason only, you must remove the gallbladder. What are the complications of this pathology, this cholecystectomy? Okay, liver dysfunction and biliary cirrhosis, white bile formation and liver failure, ascending cholangitis and suppurative cholangitis, liver abscess, septicemia, gallstone pancreatitis is CBD stone impacted in the common channel of CBD or common bile duct. Case number 4, 50-year-old lady was brought to the hospital with complaints of right upper quadrant pain, jaundice, fever with chills for the past 1 week. Thus, history of high color urine, pale color stool, and skin itching is present. Patient was slightly confused. On examination, temperature was 102, heart rate is 110, BP is only 90/60. Abdomen, slight tenderness in right upper quadrant, but no mass palpable. This no mass palpable is very important. Okay, that is very important. But this patient is having 5 things, right? Upper quadrant pain, jaundice, fever, is febrile, and he is also hypotensive, altered mental status because slightly confused. So this is what is called Reynolds Painter. So what is your diagnosis? Patient is having all these 5 things. It is a case of suppurative cholangitis. Because patient is having all these things, apart from that, patient is also passing high color urine and having pale color stool. This is a case of Reynolds Painter. What is the investigation in figure 1 and its finding? This is again ERCP, but here you are seeing stones not only in the common bile duct, plenty of stones in the common bile duct, but apart from that, you are seeing stones in the gallbladder as well. Here also you are seeing. What would be the LFT and urine exam reports in this patient? Urine shows presence of bilirubin and absent urobilinogen. LFT, total bilirubin is increased. Direct is more than indirect. Alkaline phosphatase and GGT both are increased. That is showing biliary pathology, hepatobiliary pathology. SGOT and SGPT both are mildly elevated. In figure 2 and figure 3, what are you seeing? Figure 2, this is, and you are seeing a stent inside the common bile duct here. It is going up into the liver. Okay, through the ERCP, they have put a stent inside. This is a case of suppurative cholangitis. So there are 2 types of treatment. You can put a stent here, and the end of the stent will come through the nose. This is called nasobiliary stent. This is one method of treating suppurative cholangitis. Because here, if you are able to remove the stone, that is the best treatment. If you are unable to remove the stone, at least you can negotiate it and you can put this stent. Okay, suppose if you are even unable to put the stent, then you can go for this procedure. This is called PTBD, percutaneous transhepatic biliary drainage. See, you are seeing the dilated intrahepatic biliary radicals, and here you are seeing a very thin needle that you can poke through the skin, through the liver, into the one of these dilated intrahepatic biliary radicals. The moment you are poking this intrahepatic biliary radicals, because the bile is under tension inside, all the infected bile will get drained through it. Instead of this needle, you can put a drain inside, pigtail catheter. Okay, all this infected bile will get drained. This is only a temporary measure. And okay, when once patient is stabilized hemodynamically, what else you have to do? Patient should undergo, like the previous case, either open or lap cholecystectomy, that you shouldn't forget. Either in the same admission or within couple of months. This is what we did. I told you for the previous case scenario also. So case number 5, 74-year-old woman complains of intermittent generalized abdominal pain, distension, and vomiting for almost a week. Over the last couple of days, this has become continuous, for which she has been admitted as a surgical emergency. On examination, she is dehydrated because of repeated vomiting, with sunken eyes, dry tongue, loss of skin turgor. So he is dehydrated. Abdominal examination reveals generalized distension and tenderness without any lumps or any scar in the abdomen. So what is the investigation done in figure 1 and findings? This is a plain X-ray abdomen. You are seeing a shadow here, a rounded opaque shadow you are seeing here, and you are seeing dilated small bowel, and you are seeing gas in the portal vein also here, portal system. So extrahepatic biliary radicals in CBD, you are seeing the gas. So this is what is called, these three things are called Wriggler's triad, dilated small bowel, a radio opaque shadow in the right lower quadrant, and this is what is called pneumobilia, presence of air in the biliary tract. So this is characteristic of gallstone ileus. That is the diagnosis. Yeah. And patient will present with small features of small bowel obstruction. And what is this investigation? Figure 2. This is a CT coronal view. You are seeing dilated small bowel loops here, but we are not seeing the radio opaque shadow here in the right iliac fossa, but you are seeing a fistula itself, cholecystoduodenal fistula here. You are seeing, that is what you are seeing here. Investigation and what is the finding? What is the cause for this pathology? Okay, the repeated bouts of cholecystitis result in adhesion of the gallbladder to the small bowel, usually duodenum, with eventual fistula formation and passage of gallstone into the duodenal lumen. The most common site of entry by erosion is into the duodenum. Small stones presumably pass without any problem. However, large cholesterol stones can become impacted, typically at the ileocecal wall, producing small bowel obstruction. So, what is the treatment for this? After resuscitation, she needs definitely laparotomy. The gallstone is milked proximally to a healthy proximal part of the ileum, and you have to do a ileotomy, remove the stone, and then you have to close the bowel. This is what you have to do. Usually, at the same time, you need not do anything to the cholecystoduodenal fistula, but eventually you have to do a cholecystectomy. As a follow-up, you must do that one. Case number 6. This is a 45-year-old woman complains of right upper quadrant pain, jaundice with pruritus, and swinging pyrexia, which at its height, that is 41 degrees Celsius. Her LFTs are deranged with an alkaline phosphatase of 790 units. An ERCP shows dilated common hepatic and intrahepatic ducts. Only it shows only common hepatic duct and intrahepatic duct dilatation and an inflammatory mass in the region of callous triangle. So all these findings are very important because this dilatation of only the common hepatic duct and intrahepatic duct is very important. See this with this picture, what is your probable diagnosis illustrated here in this picture? This is a gallstone. You are seeing plenty of stones, but one of the stones have gone there, stuck in the Hartmann's pouch, the neck of the gallbladder. Okay, it is unable to go through into the CBD through the cystic duct. Maybe probably it's too big. So it is compressing the common hepatic duct. Okay, and then okay, the proximal to that, even the intrahepatic biliary radicals will get, dilated, but not the distal part here. The CBD is not dilated. This is very characteristic. The diagnosis is called Mirices syndrome. Yeah, what investigation being done in figure 2 and explain the findings. Okay, you are seeing the scopy. So this is a ERCP. You are seeing an ERCP. You are seeing a mask here. A filling, you are seeing something here. You are seeing intrahepatic biliary radicals are dilated. Even the common hepatic duct is dilated, but not the CBD is not dilated here. Below this area, this CBD, this is not dilated. Only the common hepatic duct and the proximal intrahepatic biliary radicals are dilated. Okay, that is what you are seeing in this. Explain the reason for your diagnosis. Number 3. Patient is having features of obstructive jaundice. ERCP is showing dilated common hepatic and intrahepatic ducts only, and an inflammatory mass in the region of callous triangle compressing the CHD. This is the reason why we are telling it is Mirices syndrome. So what is the classification? There are two types of classification. In 1982, Mexery classified into two types. External compression of common hepatic duct by stone in cystic duct or the Hartmann's pouch. Type 2, usually there is formation of cholecystocholidoctal fistula produced by the calculus eroding into the CBD. This is one classification. In 1989, Sanders came out with another classification where type 1 is the same, the external compression of CBD by the gallstone stuck in the Hartmann's pouch, but type 2 is cholecystobiliary fistula, where one third of CBD circumference is involved. Cholecystocholidoctal fistula only. Type 3 cholecystobiliary means cholecystocholidoctal fistula, where up to two-thirds of the CBD circumference is involved. In type 4, here also cholecystocholidoctal fistula, where there is complete destruction of the wall of CBD. Okay. So how will you manage this problem? Usually a stent is required in short term to relieve the obstruction initially. A laparoscopic cholecystectomy is then, but doing a laparoscopic cholecystectomy is very difficult, almost impossible because lot of inflammation, fibrosis and a mass in the callous triangle. So you are likely to injure vital structures. So it is better to do open surgery, or even you can do only subtotal cholecystectomy. That only you can do safely without producing any injury. This is how you have to manage Mirices syndrome. Case number 7. 72-year-old man complains of severe itching all over his body for 6 weeks. He has been passing fecal urine and pale color stools. His family noticed that he was becoming increasingly yellow in color. On examination, besides scratch marks all over his body, he has a smooth, globular, non-tender mass in right upper quadrant. This is diagnostic. Patient is having globular mass. He is a case of obstructive jaundice because he is passing no high color urine and pale color stool, and he is having a non-tender mass in the right upper quadrant. So this is what is called Kurzweil's law. I'll be discussing all these things. What are the differential diagnoses to this clinical picture? Okay, the DD for the clinical picture are carcinoma of the head of the pancreas, periampullary carcinoma, or it could be cholangiocarcinoma. However, periampullary carcinoma present differently in that the jaundice waxes and wanes. Both CA head of the pancreas and cholangiocarcinoma have steady progressive jaundice. Okay, not like periampullary carcinoma. In figure 1 and figure 2, what you are seeing? Figure 1, it is an ERCP. You are, and okay, here you are seeing a filling defect, and it is not a smooth tapering of CBD. It is having the soldering effect. Suddenly it becomes very narrow. So this looks like a tumor there. So tumor in the bile duct is known as cholangiocarcinoma. That is what you are seeing here. In figure 2, PTC or percutaneous transhepatic cholangiogram showing hilar cholangiocarcinoma. This is known as Klatskin's tumor and a stent in the CBD for nasobiliary drainage. Both you can see here. There is a stent in the CBD, and okay, this is the thing you are seeing here. Okay, Klatskin tumor. What is the diagnosis? It is cholangiocarcinoma. History of jaundice being progressive jaundice suggests a malignant stricture which can be confirmed by ERCP, MRCP, and PTC, percutaneous transhepatic cholangiogram. There is a slight male preponderance with a peak incidence in the 6th decade for cholangiocarcinoma. What is a Klatskin tumor? Okay, this is the classification. Bismuth classic. Type 1 involves the common hepatic duct, spares the bifurcation. You can see only the common hepatic duct is involved. Type 2 involves the common hepatic duct and the bifurcation also. See, bifurcation is also involved. Type 3A, the tumor extends into the right branch of the hepatic duct. See, it is extending only to the right side here. 3B, tumor extends into the left branch of the left hepatic artery. It's going here. And type 4, tumor extends to both right and left branches. Okay, if you are having tumor, any tumor around this area, okay, this is called Klatskin tumor. What are the risk factors for developing this cholangiocarcinoma? Those patients who are having chronic gallstones, choledocalcis, primary sclerosing cholangitis, and chronic parasitic infection. All these patients can develop this cholangiocarcinoma. How will you manage this case? Proximal tumors, you have to resect with a Roux-en-Y hepatico-jejunostomy. If tumor is proximal, you can resect it. Distal tumors, you have to do Whipple's procedure. If both hepatic ducts or the main trunk of the portal vein are extensively involved, the tumor is unresectable. You cannot do surgery for these cases. Case number 8. A 52-year-old man presented with right upper quadrant pain with high-grade fever, with chills and vomiting for past 4 days. There was history of biliary stenting for choledocholithiasis 10 days ago. On examination, there was severe tenderness in right upper quadrant. The ultrasound and CECT scans of the liver are shown here. What are the findings in figure 1 and figure 2? What is the most probable diagnosis? Here you are seeing an ultrasound finding, and here this is a CECT finding. Here you are seeing C. This is a hypoechoic, this is the abscess cavity. This is the liver. So inside the liver you are seeing a big abscess cavity, hypoechoic area, and inside you are seeing lot of debris also. This is what you are seeing. Patient is also febrile. Yeah. So this is what you are seeing here. And here in the CECT, you are seeing the rim enhancement, which is very, very characteristic of pyogenic liver abscess. That is the diagnosis in this case. What are the causative organisms for this pathology and how they spread to the liver? The organism cultured include gram-negative aerobes like E. coli, Klebsiella, Proteus, aerobic Streptococcus, Staphylococcus, Pseudomonas, and fungi. Route of invasion, it could be through the biliary tree, that is the most common route, or could be portal vein, pylophiliitis due to diverticulitis, appendicitis, perforation, etc. But it's rare nowadays. Or invasion may be through the hepatic artery. This is because of systemic bacteremia associated with multiple microabscess. Or sometimes it could be direct extension or from trauma. These are the roots of, invasion. What is the complication? Rare complication develop in Klebsiella associated abscess. This rare complication in Klebsiella abscess is known as endogenous endophthalmitis. This occurs in 3% of the patient. It is very common in diabetic patients. How will you treat this case? Pyogenic liver abscess. Percutaneous catheter drainage along with broad spectrum antibodies. You can use an ultrasound guidance. You can put a catheter inside, pigtail catheter, and you can drain it. Along with, you have to give, of course, antibiotics. Surgery is reserved for those who fail this percutaneous technique and for those whom for surgery is required for some other pathology or already the abscess is ruptured. Then you have to resort open surgery. Case number 9. 60 years old man returned to UK after working 3 years in Indian subcontinent in a rural area. Now for the past 3 months, he is having right upper quadrant pain, mild fever and lethargy. On examination, tender hepatomegaly present. There was history of bloody diarrhea when he was in India. This is diagnostic, bloody diarrhea. His ultrasound and CECT of the liver are shown. Ultrasound you are seeing here. What are the findings in figure 1 and figure 2 and what is the most probable diagnosis? Okay, here also you are seeing ultrasound, you are seeing a hypoechoic area with few debris only here. But here in the CT scan, CECT, you are not seeing any rim enhancement. And patient is also not highly, febrile. So all these things are denoting, and patient is having bloody diarrhea while he was in India. So this is most probably a case of amoebic liver abscess. So what is the organism? Here, the most probable thing is amoebic liver abscess. The causative organism is Entamoeba histolytica. It is almost and always secondary to amoebic ulcers on the colonic wall. Due to liquefaction necrosis of the liver, the abscess results in what is called onchocerciasis. Diagnosis is by isolation of the parasite from the liver lesion or the stool. Enzyme immunoassay, EIA, ultrasound, CT scan, and nuclear scan, thallium, all these can be done. Amoebic abscess does not contain leukocytes and hence it won't get light up in this thallium scan, thallium nuclear scan. How to differentiate? Okay, amoebic abscess from pyogenic abscess. Amoebic abscess relatively younger age compared to pyogenic abscess. Male is to female ratio 20 is to 1. Here it is 25 is to 1 pyogenic. Solitary abscess is common in amoebic abscess 80%. Whereas pyogenic only 50% of them are solitary. Diabetic is more common in pyogenic abscess whereas is uncommon in amoebic abscess. Jaundice again more common in pyogenic, uncommon in amoebic. Elevated alkaline phosphatase is common in both the condition. Positive blood culture is there in pyogenic abscess but not in amoebic liver abscess. Positive amoebic serology is there in amoebic liver abscess but not in pyogenic liver abscess. So what is the treatment? You can give oral metronidazole 750 milligram 3 times a day for 10 days. This is the drug of choice. Or you can give injection. Emitin IM injection is very effective for invasive amoebiasis. Therapeutic aspiration is usually avoided. Usually you have to give only metronidazole. Metrogel is the treatment of choice and about 90% of the cases respond very well. Indication for aspiration, abscess wall diameter is larger than 5 centimeter. Okay, high risk for rupture. Abscess in the left lobe of the liver, again high risk for rupture. For diagnostic unsaid, if you are unable to make a definitive diagnosis, then also, okay, you have to do aspiration. Failure to respond is medical treatment. Failure to respond to the metronidazole in 3 to 5 days, then also you can aspirate. So this is the treatment for this patient. Case number 10, 70 years old man who has worked with sheep all his life, present to his general practitioner with right upper quadrant pain. On examination, he looks well, but in some discomfort from his pain. He has a smooth, slightly tender mass in his right subcostal area. The mass freely moves with respiration, and fingers cannot be insinuated between the mass and the right costal margin. So these are the two pictures and these are the four questions. What are the findings in figure 1 and figure 2? And what is the most probable diagnosis? Figure 1, okay, this is a CT scan of the right upper quadrant. You are seeing the liver. Inside the liver, you are seeing a very huge cystic mass. And inside this single cystic mass, you are seeing so many smaller cysts inside a very big cyst. This is very, very characteristic of hydatid cyst. So this is an intra picture where you are seeing, this is the cyst, intact cyst. They are removing with hydatid fluid, but you have to cover this area with abdominal pack soaked in scolicidal agents. So that even a drop of this hydrated fluid shouldn't spill over into the peritoneal cavity. Otherwise, if it is getting spill over into the peritoneal cavity, patient will go for number one anaphylactic shock and he will develop this hydrated cyst everywhere in the peritoneal cavity. So you have to wall off this area with packs, abdominal packs. It's very important. What is the causative organism? The causative organism is Echinococcus granulosus. This is the most common. Other organisms are Echinococcus multilocularis. Dogs are the definitive host. Sheep are intermediate hosts. And humans are only accidental hosts. The oncospheres reach the liver or lungs, where the parasite develops into the larval stage called the hydatid cyst. Diagnosis, you can confirm by an ultrasound or CT scan. Ultrasound show multiple loculi, that is rosette-like appearance or water lily appearance. Whereas CCT shows a smooth space-occupying lesion with several septae with a classical cyst inside a large cyst appearance. How will you treat this case? Primarily, this is surgical treatment, but introduction of PAR has totally replaced it. What is PAR? Okay, we will see it. During surgery, okay, I told you already, packing of the abdomen from the cyst is very important because of the anaphylactic reaction that may occur if cyst ruptures into the peritoneal cavity. Yeah, that is why, okay, you have to do this. Anaphylactic shock, not only that, the patient will develop hydatitis everywhere in the peritoneal cavity. Percutaneous aspiration, infusion of scolicidal agents, and re-aspiration is known as PAR procedure. Scolicidal agent, because you have to initially aspirate and then you have to inject some scolicidal agent inside, then again you have to re-aspirate. Okay, you must know the scolicidal agents because that is what you have to inject inside. These colicidal agents will kill the hydrated larva. They are 20% hypertonic saline, 0.5% silver nitrate, 95% ethanol, absolute alcohol, mebendazole, 2.5 microgram per ml also you can give. Case number 11, 30 years old man who has recently arrived from Southeast Asian countries complains of malaise, anorexia and weight loss. He has a dull right-sided upper abdominal pain, suffers from low-grade fever and is slightly jaundiced. He has a hard right hypochondrial mass extending 8 centimeter below right castor margin and it moves with respiration. See here you are seeing this abdomen. This is the legs end. This is the foot end. Sorry, this is the foot or leg end. This is the head end. So this is what they are palpating. Looks like a big mass in the upper part. Looks like a liver mass. The patient is having right upper quadrant pain only. And while the patient is doing this test, he couldn't insinuate his finger between this mass and the right castor margin. That mass is extending 8 centimeter below right castor margin. See, it is extending here. What are the findings in figure 1 and 2 and what is the most probable diagnosis? Figure A is showing gross hepatomegaly, which should be explained as how many finger breadths or centimeters below the right castor margin. Also feel for consistency and surface of the liver, whether surface is smooth or nodular, whether it is smooth in consistency or hard in consistency, all these things you have to find out. In figure 2, CECT showing multifocal hepatocellular carcinoma. This is what you are seeing, multifocal, here, 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 here. You are seeing multifocal, this one, and multifocal hepatocellular carcinoma. What are the investigation you should do? Blood investigation, hematological and biological to include tumor markers. Alpha fetoprotein is raised in more than 80% of these cases. Should be followed by ultrasound of the abdomen, contrast enhanced CT, and contrast MRI. To accurately stage the disease, CT of the chest and bone scan are done. What is the uh, what is the pathology of this condition? The causes are liver cirrhosis from hepatitis B and hepatitis C. Other causes are alcoholic cirrhosis, hemochromatosis, and aflatoxin contaminated food. Pathologically, there are three types: solitary hepatocellular carcinoma, multifocal, and diffuse hepatocellular carcinoma. This hepatocellular carcinoma spreads centrifugally, extending into the surrounding parenchyma and invading the portal and hepatic veins. How will you diagnose this case? Vast majority are diagnosed late, average survival being less than a year. Type of treatment depends upon severity of underlying liver disease, which is best assessed by the Child-Pugh criteria. Patients with advanced liver disease do not do well following liver resection, while hepatocellular carcinoma in non-cirrhotic liver have a better prognosis after surgical resection. Local or segmental resection carry a better prognosis than major resection, as most patients will be unsuitable for surgical resection. Non-surgical options are considered. Sorafenib is the main chemotherapeutic drug. You can also use radiofrequency ablation in unresectable tumors. You can do chemoembolization, transarterial chemoembolization, it's called TAS. Or you can use drug-eluting beads also, that is yttrium 90 radiation, glass microspheres also you can use. You can use intra-arterial chemotherapy also. The same sorafenib you can use. These are all conservative treatment. If tumor is unresectable, you have to resort these things. Case number 12, 55 years old woman has dull abdominal pain of 6 weeks duration. Pain is continuous and not related to food or bowel movement. On examination, her upper abdomen looks full, slightly jaundiced, and has an enlarged nodular liver. She has a long midline abdominal scar and left iliac end colostomy. Left iliac end colostomy following AP resection 3 years ago. What are the findings in figure 1, figure 2 and figure 3? So this is a post-mortem specimen. This is a CT scan. This is a CT PET scan. Okay, what are the findings in these three things? Figure 1, it is a post-mortem picture of liver showing multiple secondaries in the liver. Figure 2 is showing CECT of the upper abdomen, showing secondary in the liver, obviously from the primary rectal carcinoma. Figure 3, it is a PET CT scan liver showing the uptake of fluorodeoxyglucose by secondary cancer cells in the liver. And number 2, describe the pathology and what are the other sites of primary. Metastasis or the commonest malignant liver tumor. Surface of the secondary feels depressed, umbilicated, giving a volcano appearance. Spread to the liver is hematogenous. Primary source is GI tract, breast, lung, pancreatic carcinoma, malignant melanoma, and hematological malignancies. What are the investigations you will do? You have to do all routine blood investigations, hematological, biochemical, and tumor markers. You should do LFT, CT colonography or colonoscopy, contrast enhanced CT scan, CCT, MRI, and positron emission tomography, PET CT scan. How will you manage this case? The multidisciplinary team or the tumor board plays an important part in decision making process. The choice will depend upon the patient's condition, the number of secondaries, and availability of treatment options. If one single large secondary is present, chemotherapy may be considered to downstage the tumor size. This can then be reassessed and then secondary hepatectomy is considered. This is only if there is solitary secondary. Sometimes resection can be done in 2 stages depending upon the anatomical situation of the secondaries to enable the liver parenchyma to regenerate between the operative procedures. Case number 13. A 36-year-old alcoholic who presented with severe upper central abdominal pain radiating straight to the back. He had few episodes of vomiting also. On examination, epigastric tenderness and GORDing both are positive. What can be seen in picture 1 and 2? You are seeing with this central abdominal pain radiating straight to the back. That means patient is an alcoholic. This is a case of acute pancreatitis. Okay. And what you are seeing in picture 1 and picture 2. Picture 1, it is showing colon cutoff sign, a dilated transverse colon overlying an inflamed pancreas that has gone in for ileus. The figure 2 is a CT scan showing acute pancreatitis with peripancreatic inflammation and edema. Pancreas is still well vascularized and you can visualize the pancreatic duct. See, this is the pancreas you are seeing here. And this is the colon cutoff sign where you are seeing the transverse colon shadow. Transverse colon is full of gas inside because it has gone for ileus, because pancreas is situated somewhere here only. And this is that one. How do we confirm the diagnosis? Lab investigation, serum amylase and serum lipase can be done. Fourfold increase of the normal level. The diagnosis, of course, of acute appendicitis. Imaging, CACT can be done. Inflamed and edematous pancreas you can see, and peripancreatic tissue also inflamed. The necrose areas in the pancreas, it don't usually take up the radiopaque dye. That's called it is not getting light up. It will be having hypoechoic areas. How will you manage initially? Volume resuscitation, analgesia, close monitoring, and identify the cause to prevent the recurrence. If infected, then only you have to do laparotomy and necrosectomy with lesser sac lavage, continuous drainage or lavage. What are the different scoring systems you know? Ranson's, Glasgow Emery, Apache 2, Balthasar, and BISAP. Among all these, BISAP is the best one because immediately you can say whether your patient is having, a very severe problem or not by BISAP one. Because the other method, you have to wait for 48 hours. What are the complications? Early complication, necrotizing pancreatitis, which can lead to infected pancreas. Pancreas or necrosis. That is called pancreatic abscess. Late complication, it is pseudocyst of the pancreas. Case number 14. 55-year-old woman present with one-day history of acute abdominal pain in the epigastric region, which radiates through to the back. She has a long history of recurrent acute abdominal pain over several years, which had resulted in several admissions to hospital in the last 18 months. She has recently lost 4 kg of weight. She has smoked 20 cigarettes a day for 15 years and she is an alcoholic. On examination, epigastric tenderness is positive. And these are the three investigation picture you are seeing here. These are the 6 questions. What can be seen in figure 1 and 2 and 3? Okay, we will go and yeah. Figure 1, it is plain abdominal x-ray showing gross calcification in the pancreatic area. You can see it. See gross calcification here. Okay, here this is a CT scan, CCT, where you are seeing, okay, CCD atrophy of the pancreas actually. This white arrow. Pancreatic duct is dilated, but pancreas parenchyma is atrophied. And pancreatic calcification, you are seeing it in white color. And figure 3 is ERCP showing dilated pancreatic duct, strictures in the pancreatic duct, and pancreatic calcification, that is producing chain of lax appearance here. See here, definitely you are seeing the chain of lax appearance here. Here you are seeing atrophy of the pancreas here, and few calcification also you are seeing that here, here. These are all calcification. What is the probable diagnosis in this case? The most probable diagnosis is chronic pancreatitis. The hallmarks of chronic pancreatitis include episodic recurrent abdominal pain, malabsorption, malnutrition, steatorrhea, type 2 diabetes, and pancreatic calcification. So, what is the etiology of this condition? Detailed summary of the multifactorial etiology of chronic pancreatitis can be remembered by the mnemonic M. Anheim. N means multifactorial. Anheim, A is alcohol consumption, N is nicotine consumption, another N is nutritional factors, H is hereditary, E is efferent duct factors, I is immunological or autoimmune, and M is metabolic. What is the pathology? The pancreatic stellate cells are activated by the inflammatory cytokines, transforming them into myofibroblasts like cells that instigate fibrosis. It is characterized by progressive inflammation and fibrosis of pancreas, leading to irreversible structural changes, causing both endocrine and exocrine dysfunction. Unlike the chronic pancreatitis, there is no structural change in acute pancreatitis. This is what we are seeing here in the what is the difference between acute pancreatitis and chronic pancreatitis. Acute is isolated episode. Chronic is ongoing, repeated episodes. Active inflammation, these are chronic changes. Sudden and severe. Here, this is not sudden, it's a chronic, and symptoms will fluctuate. Short term, this is long term. Days to week, this is months to years. Elevated pancreatic enzyme, but here in chronic pancreatitis, normal pancreatic enzyme, amylase and lipase. Common causes alcohol and gallstone. Here, common causes recurrent acute episodes and alcohol also, and hereditary is another important problem here. How will you manage this case? Management is palliative, aiming to improve and maintain patient's quality of life. The main thing is pain control. You have to give opioid analgesic or ductal decompression if there is ductal dilatation. Otherwise, you can give celiac nerve block and splenic nerve block for pain control. Nutrition can be improved by giving supplement of pancreatic oral enzyme replacement, insulin for type 2 diabetes, surgery for intractable pain. It can be decompressed by the pancreatojejunectomy. Side to side pancreatojejunectomy can be done if patient is having chain of lax appearance. Yeah, you can go for this surgery. Case number 15, a middle-aged man with a history of alcohol abuse and several previous episodes of acute pancreatitis requiring hospitalization, present with vague upper abdominal pain, weight loss, and early satiety for the past several months. Physical examination reveals a non-pulsatile fullness in the epigastric region with minimum tenderness to palpation. Barium meal exam and CCT of the abdomen were done and shown here. What can be seen in figure 1 and 2? This is a barium meal where you are seeing the external compression here from this area. Most probably from the lesser sac it is compressing. So probably it is a case of pseudocyst pancreas. And in the CT scan, you are clearly seeing the pseudocyst. This is the pseudocyst. Okay, the most probable diagnosis is pseudocyst. This occurs following acute pancreatitis, trauma, or chronic pancreatitis. Pseudocyst takes 4 weeks to form. It should be distinguished from acute peripancreatic fluid collection and pancreatic abscess. So what are the investigation? The confirmation is by either by ultrasound or CT scan. ERCP and MRCP investigation, not often necessary, help to delineate the anatomy of the ductal system and will demonstrate if the cyst is having communication with the pancreatic duct. So what are the complications of pseudocyst of the pancreas? So it could be infection producing abscess or systemic sepsis. It could be rupture into the gut producing internal fistula or gastrointestinal bleeding. It may rupture into the peritoneum producing peritonitis, enlargement, and it can produce pressure effects producing obstructive jaundice from biliary compression. It can compress the bowel and it may go for small bowel obstruction. Patient may have pain. Erosion into the blood vessel can produce hemorrhage into the cyst or hemoperitoneum. So how will you manage a pseudocyst of the pancreas? Treatment of pseudocyst is most often necessary when the cyst is larger than 6 centimeter in diameter, causing gastric outlet obstruction and has been present for more than 6 weeks. Open surgery, the treatment of choice is open cystogastrostomy. Minimally invasive surgery, you can do either endoscopically or laparoscopic cystogastrostomy. If the cyst lies laterally near duodenum, then you can go for cystoduodenostomy. Roux-en-Y cystojejunostomy also can be done if the cyst lies away from both stomach and duodenum. Case number 16. 58-year-old man with 50-pack year smoking history present to his doctor after family members noted that the eyes were turning yellow. He has developed pruritus and clay color stools over past 2 weeks. He describes darkening of his urine and a 15 pound weight loss over the past 2 months. On examination, there is scleral icterus and non-tender globular right upper quadrant mass present. So these are the two pictures and these are the 7 questions. What is your probable diagnosis with this clinical picture and with this CT abdomen and the ERCP? Okay. The diagnosis is carcinoma of the head of the pancreas. Reason for diagnosis, patient is an elderly one, he is smoking 50 pack, pale color, he is passing pale color stool and high color urine with pruritus, 15 pound weight loss in 2 months, scleral icterus, globular right upper quadrant mass which is not tender. That is the Kurvaisius law. Kurvaisius law says if in a jaundice patient, if gallbladder is palpably enlarged, that is not due to gallstone. That is what Kurvaisius law is. So what are the different causes for obstructive jaundice? Intraluminal causes are choledocholithiasis, clinarchis sinensis, this is the Chinese liver flu, ascariasis and schistosomiasis. Mural cause, problem in the wall. Malignant stricture, cholangiocarcinoma. Benign stricture, sclerosing cholangitis. Extrinsic causes, carcinoma head of the pancreas, periampullary carcinoma, portal lymph node enlargement. Okay, in figure 1 and figure 2, what are you seeing? In figure 1, okay, you are seeing a tumor in the head of the pancreas. This is the pancreas, and you are seeing a tumor in the head of the pancreas. This CECT. Apart from seeing this one, you can also see whether there are any para-aortic lymph node enlargement or the involvement of the adjacent blood vessels, the superior mesenteric artery and vein, whether it is just touching these vessels or whether it is fully encircling these blood vessels, you have to look for. If it is fully encircling or encasement, the tumor is not resectable. Yeah, if it is just abutting the tumor, still you can do surgery. So here in the picture 2, you are seeing ERCP exam where you are seeing this area, there is a filling defect, both in the CBD as well as in the pancreatic duct. This is what is called, both the ducts are dilated. See, because there is some constriction here, because the tumor head of the pancreas here, you are not seeing the dye in this area. So this is where extrinsic compression over both CBD and pancreatic duct, and both the ducts are dilated here. This is called dual duct sign. Yeah, this is what and yeah. How will you confirm the diagnosis and stage the disease? Ultrasound initially, and if it shows solid mass in the head of the pancreas, then you have to go for CECT to confirm it. Also doing a biopsy by endoscopic ultrasound. Laparoscopy plus or minus ultrasound to rule out peritoneal or liver secondaries. So how will you manage this case? The radical curative surgery is Whipple's operation or pancreatoduodenectomy. Some surgeons insert a metallic CBD stent to improve liver function before doing surgery 2 weeks ago. Problems with these stents are infection and reduced CBD diameter, making choledochojejunal anastomosis very difficult. Whether doing single stage or two stage surgery is the surgeon's preference. But Whipple's operation is one of the major surgeries and prognosis is very dismal. Case number 17. 60-year-old woman present with pain abdomen and intermittent jaundice for 1 month duration. The history of loss of appetite, loss of weight present, and passing silver color stool. On examination, there is painless globular mass present in the right upper quadrant. What is your diagnosis and why you are saying so? It is a case of periampullary carcinoma because the patient is having intermittent jaundice, pain abdomen, loss of appetite, loss of weight, silver color stool, and painless globular mass in the right upper quadrant. Okay. Because the periampullary tumor waxes and wanes, there is intermittent jaundice. Because part of the tumor will get necrose, it will fall off. The compression, extrinsic compression will be relieved. Patient will be relieved of jaundice. But it will again regrow, again it compress, patient will again go for jaundice. And what is the cause for the typical or classical silver color stool? The blood from the periampullary carcinoma mixed with the acholic pale color stool due to the obstructive jaundice, yeah, and give a characteristic silver color stool. If somebody is having silver color stool, you must rule out periampullary carcinoma. In figure 1, we are seeing the upper GI endoscope. This is upper GI endoscope where you are seeing the tumor here. You can take a biopsy also directly from here. Yeah, this is periampullary carcinoma. This will bleed. Whereas in the picture 2, you are seeing endoscopic ultrasound. Through this also you can take a biopsy and you can accurately or you can precisely stage the disease. If it is a early one, whether the tumor has invaded only the mucosa, has it invaded the muscularis or serosa, everything you can precisely make out by doing this endoscopic ultrasound. What is the treatment in this patient? This is what you are seeing in this case. This is the treatment, Whipple's operation or pancreatoduodenectomy. Even though the tumor is only in the pancreas, you have to remove the duodenum also because the blood supply for both duodenum and pancreas is same. The moment you are going to, ligate the blood supply to the head of the pancreas, there won't be any blood supply to the duodenum also. That is why you have to remove both together. So after this radical surgery, you are supposed to do 3 anastomosis. That is gastrojejunostomy, pancreatojejunostomy, and choledochojejunostomy. These are the 3 anastomosis you must do in Whipple's operation.